before we even look at the rubric, you guys, a few days before your next lab or practical testing, will get something posted by Dr. Parker. It'll be 2 cases on Blackboard, one of which will give you information that makes it sound like a hypofunction case, one of which will give you information that makes it sound like a BPPV case, and you're just using your clinical judgment to pick. When you guys come back for your practical, I'll have both of the cases flipped over. I'll say who wants to be therapist first. Okay, I want to be therapist first. You flip over one and it'll say case 1 or case 2, and it'll have the whole case there. I don't think you can look at it to remind yourself a little bit, but it's going to be exactly what's on Blackboard. There's no tricks about that. So then you would say, oh, I think this is a hypofunction. And I'll say, great, do a test that would identify a hypofunction. So going back to the case, what kind of stuff in a case would tell me that it sounds like a hypofunction?
Constant dizziness.
Doesn't change with position.
It's not positional. A lot of times precipitating factors are like a hospital stay or like a illness. Like if somebody has COVID, somebody has the flu, somebody has a respiratory infection. Is there any of that? That infectious inflammation can sometimes affect that nerve there on that side. So that would tell me, hey, I think this is a hypofunction case. They might have just general dizziness with turning your head, looking around at things, turning in the car, driving bothers them. That all sounds like very vestibular hypofunction. If somebody says, hey, 3 weeks ago I laid down in bed and the room just started spinning around, and it only lasts a few seconds, but then it stops. But it's pretty vicious, spinning around when I lay down every time I go to bed and every time I get up out of bed in the morning. That sounds a lot like BPPV. Something else that might tell you, give you a hint for BPPV is head trauma, like we talked about. Somebody said, I hit my head. Other things that are known to cause BPPV, this is just for your guys' information. I don't know, this is pretty in-depth, so I don't know if you're going to be tested on it. Low vitamin D is more common for people to get BPPV. If you think about those crystals being calcium, like vitamin D and calcium make strong bones. Same thing for crystal bonds. So if they're low in vitamin D, those people have it happen more regularly to them. Happens more to women than men. Happens more to seniors over the age of 60 than younger people. So those are all things that are common. High cholesterol, so hyperlipidemia, high blood pressure, happens more to them. If somebody's getting any kind of head and neck radiation on cancers, tumors, things like that, very common for those people. So those are all things that you can see on their chart before you even meet the person. It's all right, there are all these things, sounds like they might actually have BPPV. I'm going to do on my test just to confirm that, but I already have a pretty good idea of what's going on. So let's see. Yeah, so you would say hypofunction. Dr. Vasquez, I think that's a hypofunction. Okay, show me a test for a hypofunction. What test would you like to show me? Head impulse test, otherwise known as the head thrust test. You would do that. You do it on your classmate. I say, all right, you saw their nose come off, their eyes come off your nose when you move quickly to the left, and then it came back. And then when you move quickly to the right, it stayed on your nose the whole time. What's your diagnosis?
Left hypofunction.
Left vestibular hypofunction. Yep. So, all right, that's your diagnosis. Great job. For left vestibular hypofunction, I want you to show them an exercise that they can do to help that and teach them a home exercise program. Then you would teach them a home exercise program. And before you're doing any of this testing or touching a patient, or what are you doing?
Cervical screen.
Cervical screen. That's right there on the It's on, yeah, and that's for BPPV or hypofunction. So that's one of the safety things that we have to look at. Is did you do a cervical screen? So I don't know if it's on there, but I promise that is part of it. So yeah, it is where people usually would lose points on that type of practical on the hypofunction is they do the head impulse test wrong, they interpret the head impulse test wrong, and most commonly they miss stuff when they're instructing somebody on the home exercise program. It is a very wordy practical. You have to address a lot of things, like ask their baseline symptoms, ask their symptoms during the exercise. Make sure the patient understands how to do it. Make sure you're then telling them what to do. And I'll say, oh, it's been 10 years that they've had this. Give them a home exercise program. You're telling them the correct amount to do at home and how to dose that, how to increase it, and what not to do, not to overdo it. So there are two rubrics. One is for the hypofunction, professional behavior, basic stuff, body mechanics safety, basic stuff, oculomotor assessment. We just talked about that. Demonstration of vestibular knowledge, that's getting the diagnosis right and picking the right intervention.
So then it's beat to the right. But
Next is BPPV. All right, we picked the BPPV case. Okay, Dr. Vasquez, I think it's BPPV. All right, what's a test that you would want to do for BPPV? Or the roll test. So, and then say you say Dix-Hallpike, I'll mark that as right. And I might say, show me the Dix-Hallpike, or I might say, okay, good answer, show me the roll test. So one of those two tests you would do, I would give you hypothetical results, just like I had people demonstrate the last couple labs, and then you would then have to say the diagnosis. I'm not going to be like that hardcore about like saying it. Like I know a lot of people struggle with the word canalithiasis and cupulolithiasis, but if it's wrong enough to just be something else, like I have to take off like that, which people say a lot of stuff that's not like it's not the right thing. So I would practice saying it at least. You know, if it's not totally perfect, that's fine. But if it's just something else, I can't even think of like other people say weird stuff. But yeah, so definitely just say the right thing, and then I would say, all right, you think it's this? What's a maneuver for that? And then you would do the maneuver, and then I would ask you questions about the follow-up, about patient coming back to the clinic. What do you tell them? What do you educate? All those kind of things. So that'd be pretty much it. And before you take them in the Dix-Hallpike or the roll test, you're doing cervical screen. Yeah. Pretty straightforward. Dr. Parker will post a Google Doc for sign-up times, and then after next lab. So as you guys know, this afternoon will be the evaluation and a little bit of treatment with the patients. The following lab, our last lab, will be vestibular practical in the morning. No practice time for that. I don't know that that's needed for this one as much as it is for like spinal cord injury. So we'll start just first student at 8 a.m. In the afternoon we'll have the full time for patient treatment in the afternoon. So then, is that your last day on campus? Ever?
the next
Sunday.
The following day, Sunday.
Oh, okay. So that's your last weekend on campus. Okay, very
No,
good.
y'all won't come back. No, y'all come back on the 29th for the MPCE thing.
That's before though.
We're in March.
Yeah, but this is in April.
It says March 29th on the paper for you.
So we would already have done it.
I don't know, I'm gonna be here, sorry.
April 11th is when I will see you guys for your last day of lab for this class. You guys don't have to come back after that, right?
No.
No.